Society for this very nice invitation, which allows me to come back to Egypt after 20 years. I'll try not to wait another 20 years to come back. And I'd like to share with you a few thoughts on the way we think about rejection and the definition of rejection. And I think it's very important to realize that we are in a very unique situation because today the definition of rejection is the same in Cairo, in Paris, in Sydney, or in New York. And this is very important because when you read the papers and you say, this treatment gives you less rejection, if you don't have the same definition of rejection, this is not going to help you. So it was very important to come to a common definition so that we could do clinical trials and could compare the results from one center to another. And this started 22 years ago with those two people here. Oops, do I have a pointer? No. Well, anyway. Wow. Okay. These are two pathologists that decided that they should make sense of what was called rejection. And for those of you who don't know why it's called the Banff classification of rejection, it's just because the first meeting was in that very nice, very little and very far away city called Banff in the Rockies, in the Canadian Rockies. And there, year after year, the Banff classification appeared and evolved. And it's a very unique phenomenon because it's not part of any society. It's not part of the International Transplant Society, it's not part of the Nephrology Society, it's not part of any society. It is a society by itself. There is no fee to get in, so you're most welcome. And all we're asking for you is to work with us. So it's a moderated, self-organizing group. You don't have that many nowadays. That works fine. And the principle was that everyone will speak in one language and that we'll all agree on definitions on what was allograft pathology. So it's been on for a number of years. You can see here all the meeting is every other year because in 1 year there's not enough progress to hold the meeting. And the first thing that was done was to create the only international classification. So you can see that in 1995 there was a CADI classification that came from Northern Europe that joined with Banff, and then in 1997 even the Americans agreed to let down their own classification, the CCTT, and join the Banff. And then you can see, for example, in 2001, the definition of antibody-mediated rejection, which you heard a talk about. And fortunately for us, in 2007, we managed to get the Banff meeting out of Banff, because, for example, for me, it's a 36-hour travel to get to Banff, and for numerous people. So now Banff is going around the world. It was in Paris 4 years ago. It was in Brazil 2 years ago. It's going to be in Vancouver this year. So it moves around. And as you can see, it's been extremely productive. You can see here the number of papers that are based on that classification, and every one of you reads papers about immunosuppressive regimen and rejection, and all the rejections are classified following that classification. Now, it's very difficult to work with that classification and to change it, because if you change too often, then people won't know the classification, and then you can make mistakes. You're going to say, oh, this is fantastic, and then 2 years later, you realize it's a mistake. On the other hand, it has to move and it has to evolve because we gain knowledge every year or every other year on what's going on. So I'd like to show you two major changes that have been put into place in the Banff classification in the last couple of years. The first one is the place of vascular lesion in rejection. You all know vascular lesions, and we know for the longest time that it was not good. This is an old paper published in 1999, looking at biopsies of patients. You can see here the survival at 6 months and 5 years if there's no vascular lesion, which is fairly good, 95% 6 months, 78% 5 years. But if there were vascular lesions, you can see that the prognosis is not as good, with barely half, a little more than half of the grafts surviving 5 years. Again, in another study in Canada, you can see again that the rate of failure doubles if you have vascular lesions. And you can say, well, these are all data, and now we have tacrolimus. Well, you can look into that nice French study, and these are patients treated with tacrolimus, and as you can see still see a worse prognosis in case of vascular rejection. So we got interested with comment for showing by unit because there was something wrong with the Banff classification, because vascular lesion in the Banff 2007 classification could be part of T-cell mediated rejection or of antibody-mediated rejection. And we say, you can't be in both sides. Is that really something serious? So we thought that vascular lesions are different from T-cell mediated rejection, and for two things. The first one that you all know is that vascular rejections do not respond to steroid therapy, and we all know that steroid therapy is the treatment of T-cell mediated rejection. The second one, which we found looking at humoral rejection, is that if you have a classical humoral rejection, and if you have vascular lesion, then your prognosis is worse. So we decided to investigate this, thinking, well, on the one hand, the classical view is vascular rejection is cellular. On the other, you have humoral rejection. So how do they mix? Do every vascular rejection is humoral, or is that a 50-50 mix, or is that essentially cellular rejection? So to answer that question, we undertook a common effort with another transplant group looking at immunology, biopsy, and population analysis. So we looked at 2,700 transplant patients, 300 biopsies, and we looked at the Banff parameters, the anti-HLA antibodies that we could find by Luminex technology, and obviously the C40 staining. So this is the, okay. So this represents the lesions. So here you have, under that very nice timer, you have I and T, infiltration and tubulitis. And you can see here that these are the very classical cellular rejections, which are I and T, so these are T-cell mediated rejections. Here, on the bottom line, you can see the very classical humoral rejection with peritubulocapillarylitis, glomerulitis, presence of donor-specific antibody, and C40 staining. So that's fine. The problem is here, where you have a mix of cellular rejection with cellular infiltrates and inflammation, and maybe DSA or capillaritis. So how does that work? Well, we did unsupervised cluster analysis, and you can see here that you can see the classical T-cell mediated rejection, you can see the classical antibody-mediated rejection, but there was another type of rejection that we haven't seen before, which is the presence of vascular lesions in the context of donor-specific antibody, and a little bit of vascular rejection without donor-specific antibody. And actually, to answer one of the first questions, you can see that in our series, in 71% of the patients with vascular lesions, there was a donor-specific antibody. Now you could say, well, this is very nice, and I made the nice publication, but what's the use? Well, the use is as follows. On this panel, this is graft survival with the classical Banff classification. No rejection. In blue, you got the T-cell mediated rejection, and in that purple, you got antibody-mediated rejection. Now, if we incorporate the V, and we do, again, the analysis, you can see here that this very poor prognosis are vascular rejection with donor-specific antibodies, and that finally, the humoral rejection without vascular lesion is not that bad. It's worse than other things, but that means I think we now have a good handle on how to treat it. So it's antibody-mediated vascular rejection is a distinct entity. And what was very interesting for us is, is to realize that actually it was not only for the microcirculation, like the glomerulus or the peritubular capillaries, but it could be in a number of other vessels. And this was the late Gary Hill that developed this. And what he did is looked at atherosclerosis in transplant patients with or without donor-specific antibody. We all age, so obviously, the lesions don't get better year after year. But what he discovered is that 1 year with donor-specific antibody equals to 29 years without antibody. And this is how it reads. This is quite complicated, but if you don't have any antibody, this is how your vessel age. So in 1 year, you go that way. But if you have donor-specific antibody, then in 1 year, it's 29 years. So we looked at this in heart transplant patients, and it's exactly the same thing. If you look here, this is what I showed you for kidney. This is for heart. It's exactly the same phenomenon. So there is, and there was lots of old papers about the immunological causes of arteriosclerosis. Well, here it is demonstrated for transplant recipients. So, what can we do when we know that? Well, we can try to better diagnose our patients and treat them. We looked at our series, and what you can find here is that if you look at the number of patients that we had, here we had half of the patients that had vascular lesions that were misclassified as T-cell mediated rejection. And we thought maybe if we classify those better, that is, if we treat them for humoral rejection, then maybe we can get a better graft prognosis. And we looked in our series, and these all are humoral rejection with vascular components. If you treat them the old-fashioned way, this is your graft survival. If you treat them with plasmapheresis, IVIG, thinking there's a humoral component, you can see that you can definitely get a much better prognosis. So this is not just fun for pathologists, I think it's important for our patients. The second major advance is about C4D. C4D was very important for us to get a handle on humoral rejection and to start diagnosing humoral rejection, and you all know these features by immunofluorescence or on paraffin section in immunohistochemistry of the C4D staining in the peritubular capillaries. The problem is then, as soon as we get somewhere, we start again questioning what we just get. And now we are discussing the concept of seed-dependent antibody-mediated rejection. And this is a very, very nice study by Bob Coughlin, who's a pathologist from Boston. And what he basically did is create a model of humoral rejection in the mouse, where he made a heart transplant, and then he injected the antibody directed against the donor. So you should have humoral rejection, and indeed you do, except that if you use an antibody that do not activate complement, you have the same lesions, which means that in some cases, at least, you can have complement-independent antibody-mediated rejection. And to make sure that this was the case, he took mice that were deficient for complement, and as you can see here, you have exactly the same lesion in complement-deficient mice than in normal mice. So there is the possibility of a complement-independent antibody-mediated rejection. How could that work? Well, there's a very nice lady working in Los Angeles called Ellen Reed that has been working on this. And I just want you to think that, for once, the HLA was not created only to be a problem for transplantologists. It must serve a purpose. And so if an antibody binds to the HLA complex, then obviously something happens downstream. And what happens is proliferation and from time to time apoptosis. So there's a logic to this. Alexandre Loupy in Paris showed very nicely that the C4D can vary from one biopsy to another. These are repeat biopsies, and you can see that some get increase in C4D, some get decrease in C4D, and some just disappear And you can see that in this slide, where you can see that some biopsies went from positive to positive, some from positive to negative, some were positive, positive, negative, or the other way around. So it's all a mixed bag. And C4D is very important when it's there, but it doesn't mean anything when it's not there. And this was very nicely demonstrated in Paris, where we took biopsies of humoral rejection. We looked who was positive, who was negative. And what was very interesting is that if the biopsy was C4D positive, obviously most of the biopsies had peritubular capillaritis and glomerulitis, so classical humoral rejection. But what was very interesting is that when the C4D was negative, half of the biopsies had exactly the same microcirculation lesions as C4D positive. So I think that, as Bob Colvin said, C4D was very interesting, but we have to go further than C4D. And all this can be found, led to a rewriting of the Banff classification, and was published early last year in the American Journal of Transplantation with two major changes. The inclusion of C4D negative antibody-mediated rejection for one, and the addition of antibody-associated arterial lesion in the hope that we can better classify our patient and better treat them as I showed you. So I won't go into the detail because it's getting more and more complicated because you got acute AMR with C4D, acute AMR without C4D, and then you got subclinical AMR with C4D, and then you got subclinical antibody-mediated rejection without C4D, and be very cautious because if you don't have strict definitions, then everyone will have subclinical humoral rejection, which we don't want. So this is very important. And I just want to finish with one thing which speaks to my heart, which is the C4D staining without any lesion, which is something I don't know if people here do ABO incompatible transplants, but that's how I discovered accommodation. You do an ABO incompatible transplant, and when you do protocol biopsy, renal function is normal. No proteinuria, no hypertension. The histology is perfectly normal, and when you do the C4D, you have a fantastic C4D staining, which was well demonstrated in animals, but you do see it in humans. And so now it's placed in the Banff classification, C4D staining without histologic evidence of rejection, and that might be what was called and called accommodation, at least in xenotransplantation, in ABO incompatible patients. Why don't we see accommodation with HLA incompatible transplants? I have no idea, but I would love to know. So let me finish that. I think this is a very nice story, which is ongoing, of people that just decided to join forces and find a common language for all to speak. And I'm just going to tell you that I hope a number of you will be present in October of this year in Vancouver for the new Banff meeting on allograft pathology. Vancouver is a great city, and October is a nice weather. It might even be warmer than Cairo in January. Thank you.